Hi, I'm Jared Fowler with the Florida Medical Association, and I'm here today to talk to you about MACRA and to tell you what the law is all about. And so again, I am the Director of Healthcare Policy and Innovation at the FMA, and so one of my prime responsibilities is to try and help educate doctors on new payment policies, particularly as it pertains to Medicare, managed care, reimbursement issues. This presentation is intended only as a general summary. We're not going to try and cover every aspect of MACRA during the course of this presentation. And also remember that Medicare policy changes frequently, so it's important to stay up to date on the new regulations and other materials that are released by CMS. So let's talk briefly about our learning objectives for today. We're going to review MACRA's history and its key provisions. We're going to try and understand MACRA's impact on the Medicare physician payment system, of course. Talk a little bit about some of the controversies surrounding MACRA, and also try and place the law in context with some of the broader payment reforms that are happening across the nation. So MACRA. First and foremost, what does MACRA stand for? Well, it's actually an acronym within an acronym. It stands for the Medicare Access and CHIP Reauthorization Act of 2015. Just what we need in healthcare, right? More acronyms. It was passed by Congress with overwhelming bipartisan, bicameral support, and it was signed into law in April 2015. If you know nothing else about MACRA, you probably know that it was a law that repealed the universally detested sustainable growth rate, or SGR, the formula that was previously used to update the Medicare physician fee schedule. It is also separate from the Affordable Care Act. MACRA is not tied to the ACA, and if the ACA is repealed, MACRA does not go along with it, just to make that clear. Unlike the Affordable Care Act, again, MACRA was a piece of legislation that passed with overwhelming bipartisan support. So you don't need to know a lot about the sustainable growth rate to understand MACRA, but in case you're sort of curious as to what the SGR, or what the sustainable growth rate is, the SGR was a formula that was previously used to update the physician fee schedule. And the only thing you really need to know is that the SGR works something like this. Each and every single year, target expenditures were set according to a formula. And if actual expenditures exceeded target expenditures, then across-the-board payment cuts were implemented to make up the difference. And unfortunately, this formula was flawed, and it had the potential to result in very significant cuts to the Medicare physician fee schedule, which could have resulted in devastating loss of reimbursement to clinicians and potential significant access to care issues for Medicare beneficiaries. Little piece of SGR trivia. The SGR actually did result in a payment cut to physicians and other clinicians one year, which was 2002. The SGR went into effect and resulted in a nearly 5% negative payment update. Since that time, since 2002, until the SGR was eliminated by MACRA, the SGR was overridden by Congress to prevent it from going into effect and instituting further cuts. Unfortunately, as you can see from this slide, Congress didn't always institute very significant payment updates in overriding the SGR. In 2012 and 2013, for example, Congress overrode the SGR and replaced it with a 0% payment increase. That is to say, they froze the Medicare conversion factor in those 2 years. And then in 2014, a 0.5% payment increase was implemented. This slide right here represents what would have happened had the SGR gone into effect in 2014. At the top here, you have a blue bar that represents private health insurance rates, which everything else is relative to. That orange bar represents the Medicare rate. And as you can see, on average, according to CMS's data, the Medicare rate has historically been around 80% of private health insurance rates. Obviously, that varies by specialty and practice and geography and so forth, but nevertheless, that's sort of an average. You can see had the SGR gone into effect as planned, it would have immediately resulted in a very substantial payment decrease and would have brought Medicare payment rates down to nearly the level of the average Medicaid rates, which is to say, had the SGR gone into effect as scheduled under law, it would have resulted in a very significant payment increase for physicians, which could have severely threatened access to care. So at any rate, again, MACRA repeals the SGR, and in its place, instead of having a formula that's used to update the Medicare physician fee schedule, it replaces the SGR with small predetermined annual fee schedule updates. So you can now predict what the payment updates to the Medicare conversion factor will be, as they are now set forth in statute and no longer determined by a formula. That can result in varying payment updates from year to year, such as the SGR. Another thing that MACRA does is it consolidates the Medicare Part B mandatory pay-for-performance programs into a new program called the Merit-Based Incentive Payment System, or MIPS. In other words, MACRA takes PQRS, the Physician Quality Reporting System, Meaningful Use, and the Value-Based Modifier, and it rolls them together into a new program called MIPS, or the Merit-Based Incentive Payment System. MIPS also includes a new component known as clinical practice improvement activities that we'll talk about later. The third thing that MACRA does is that it encourages participation in what are called advanced alternative payment models, or AAPMs. That is, certain types of accountable care organizations and certain types of other new modalities of payment to encourage experimentation in the Medicare payment system. MACRA does not, however, require physicians or other clinicians to participate in advanced alternative payment models, although it does provide financial incentives for those that do. So again, I'll repeat myself a little bit here early on in the presentation to kind of nail down the basics. So again, what MACRA really does then is that it overhauls the Medicare Part B physician payment system by repealing the SGR and replacing it with small predetermined payment updates, by consolidating pay-for-performance programs under Medicare Part B into MIPS, taking PQRS, Meaningful Use, and the Value-Based Modifier and using them to create this new Merit-Based Incentive Payment System, incentivizes participation in advanced APMs, and these changes are collectively referred to as the Quality Payment Program, or QPP. You hear CMS use that term quite frequently now. They refer to the Quality Payment Program, or QPP, and really that term is a term that CMS has developed to refer to the collective changes that are taking place as a result of MACRA. And major provisions of the law go into effect this year. So a while back in April, CMS released its proposed rule for implementing MACRA. This proposed rule, as many of you are aware, was met with fierce criticism from organized medicine, including the FMA and the AMA. Physician organizations felt that the program requirements under the proposed rule were unrealistic, very difficult to comply with, and most small practices, the vast majority of solo practitioners, were expected to receive penalties under the Merit-Based Incentive Payment System under CMS's proposed rule. However, in October, CMS issued a final rule wherein CMS responded to a great deal of the criticism that was levied against it. The final rule creates a transition year in 2017 for MACRA, and it expands exemptions under the Merit-Based Incentive Payment System, and it sets a minimal set of requirements to avoid penalties in the first year of the QPP. Potential to earn bonuses for exceeding the minimum requirements through a pick-your-own-pace reporting system. It revised financial risk requirements for advanced alternative payment models to make it slightly easier to participate in an advanced alternative payment model in future years. And in other words, in the final rule that CMS released, a considerable number of physician-friendly changes were instituted, and while they do not eliminate the burden that the Merit-Based Incentive Payment System and the other components of MACRA's QPP will create for physicians, the final rule does alleviate many of the concerns that physician organizations had. And so while MACRA will continue to pose a considerable challenge for many practices, the final rule that was released by CMS in October will certainly make the transition easier than it would have been had the proposed rule gone into effect. Now remember, the transition period is not permanent. CMS has created this transition period in the first year of the program, but it is likely that the transition period will slowly be phased out in future years, and therefore the program requirements under the merit-based incentive payment system are likely to increase as we move forward. So that was a lot of information. And I understand that, MACRA is a complex piece of legislation and can be a little bit difficult to grasp. So here is a slide which was originally developed by the Centers for Medicare and Medicaid Services that tries to explain MACRA in one page. I assure you this is about the best one-page explanation you can get. It's not perfect, but it does provide some information about how MACRA as a piece of legislation works in a single page. So you can see on this slide there are 3 rows of information. The first row of information explains fee schedule updates to the Medicare conversion factor. These are the statutory payment updates that MACRA has implemented that will replace the SGR. As you can see, from 2016 through 2019, a 0.5% or 0.5% payment update will be implemented as a result of MACRA. These are, again, updates to the Medicare physician fee schedule conversion factor. You can then see from 2020 through 2025, the conversion factor will be frozen, which is to say that there will be a net zero increase in each of those years. And then in 2026 and later, physicians that are participating in advanced alternative payment models will receive a 0.75% update. And physicians that are still in the fee-for-service-based merit-based incentive payment system, MIPS, will receive a 0.25% payment update. And then you can see here the second row, we mentioned MIPS. Again, the program that I discussed that's going to replace PQRS, the value-based payment modifier, and meaningful use. So the first performance year of MIPS is going to be in 2017. And then based on your performance in 2017, physicians will receive payment adjustments in 2019. In other words, MIPS works a lot like meaningful use and PQRS do already. What you do in one year will affect your payments in a later year. In MIPS, the payment updates take place 2 years out from the performance years. And so again, what you do in 2017 will affect your payments in 2019. What you do in 2018 under MIPS will affect your payments in 2020, and so forth. Now, it gets a little bit more nuanced in this, and we'll discuss how this is going to work in more detail later, but in general, the maximum payment updates in the first payment year, 2019, of the merit-based incentive payment system will be plus or minus 4%, meaning that the maximum penalty under MIPS in the first payment year will be 4% if you don't participate in the program at all. Likewise, generally speaking, the maximum bonus that a physician would be able to receive would be a positive 4% payment update. And again, we'll talk a little bit about the exceptions to that later. Now, it's important to remember that in future years, the maximum payment updates under MIPS will increase up to 9% in 2022 and beyond. And you can see here on this slide how those payment adjustments are phased in. Now, there is an alternative to participating in MIPS under MACRA, and that's to be a participant, a qualifying participant, in an advanced APM, or an advanced alternative payment model. Physicians that participate in an advanced APM, and I should use the term sufficiently participate in an advanced APM as defined by CMS, are exempt from MIPS. And from 2019 through 2024, they can earn an automatic 5% Part B payment bonus. So there are significant financial incentives for participating in an advanced alternative payment model if possible. Furthermore, as I mentioned, in 2026 and beyond, so 2026 and every year thereafter, physicians that are participating in an advanced alternative payment model can qualify for a 0.75% payment increase for the Medicare physician fee schedule conversion factor, relative to a payment update of only 0.25% for physicians that are still in MIPS. This is just a slide that sort of illustrates the timeline here for the first performance year of the QPP, Quality Payment Program. So again, the first performance year is 2017, this year. And as you can see, again, the first payment year will be in 2019. And between then, physicians will be submitting data and will have the opportunity to receive feedback that gives them an idea of where their performance lies. And so this is sort of the way that MACRA is commonly explained if you just like sort of Google it and find a random article on MACRA. The way that it's most commonly explained is, MACRA gives physicians a choice between the fee-for-service system and the merit-based incentive payment system that goes along with it, or participating in an advanced APM. However, in reality, for some reasons that we're going to discuss, the vast majority of physician practices will be subject to the merit-based incentive payment system. This is because there are only a handful of exemptions from MIPS. One, I mentioned, participating in an advanced alternative payment model, of which few are currently available, or meeting other specified criteria. So you should anticipate, unless you fall into an exemption category, that you will be subject to the merit-based incentive payment system and study the rules and regulations and guidelines that go with it. So who is exempt from the merit-based incentive payment system? There are three categories of clinicians who are not subject to MIPS. The first are physicians who are new to Medicare Part B participation, if it's your first year in Medicare Part B. The second are physicians and physician practices, or more specifically, physicians and groups based on how you report data under MIPS, who are below a low volume threshold. This low volume threshold is set at either Medicare Part B billing charges that are less than or equal to $30,000, or caring for 100 or fewer Medicare patients. That low volume threshold is not going to apply to a great many practices that take significant Medicare volume. The third exemption from MIPS is for clinicians and groups that participate in an advanced alternative payment model, or AAPM. It's also important to remember MIPS does not apply to hospitals or facilities. It only applies to eligible clinicians and groups thereof. Now, so I mentioned earlier, you can participate in an advanced alternative payment model and be exempt from MIPS and qualify for some substantial incentives. However, in the first year of the program, there are not very many advanced alternative payment models available to choose from. Essentially, there are really only 4 that are potentially available in Florida at this moment. Shared Savings Program Track 2, or MSSP Track 2 ACOs, which are risk-sharing ACOs. MSSP Track 3 ACOs, which are also risk-sharing ACOs. The Next Generation ACO model, which is a risk-bearing ACO. And the Comprehensive End-Stage Renal Disease Care model with the two-sided risk arrangement. Beginning next year, there will be some more opportunities available. But at the time, for physicians in Florida, these 4 models are the only models that are available. The Comprehensive Primary Care Plus model, which does count as an advanced alternative payment model, is not currently being piloted in Florida, and therefore is not available to Florida physicians as of this point in time. And the Oncology Care model with a two-sided risk arrangement won't be available until 2018. And we'll talk about some more models that are coming out in 2018 as well. But the big takeaway from this is that right now there are not very many advanced alternative payment models available for physicians in Florida. Consequently, again, unless the physician or the physician's group meets the low volume threshold criteria, or unless it's a physician's first year participating in the Medicare program, they should anticipate that they will be subject to MIPS. So again, let's talk a little bit more about MIPS, and this is where we'll spend most of our time, since this is probably the most substantial, or certainly the most significant aspect of the quality payment program that physicians in Florida currently need to pay attention to. And the merit-based incentive payment system has 4 components. Quality, which replaces the PQRS, or Physician Quality Reporting System, and the quality component of MIPS works very similar, reporting similar types of data through similar methods. Advancing Care Information, which replaces and is very similar to Meaningful Use, and a Resource Use/Cost component, which replaces the Value-Based Modifier, and then a new category known as the Clinical Practice Improvement Activities category that we'll talk a little bit about as well. So again, this is the first scheduled performance year. for the merit-based incentive payment system in the first scheduled payment year is 2019. When we use the term eligible clinicians for MIPS, it's important to remember that eligible clinicians include physicians, ARNPs, PAs, CRNAs, and clinical nurse specialists, and this term may be expanded to include additional clinicians in future periods. It's also important to note that the term physicians, for the purposes of MIPS, includes physicians that are MDs, DOs, but also podiatrists, optometrists, chiropractors, dentists, and doctors of dental surgery. Based on performance and the four components of MIPS that were mentioned above, eligible clinicians and groups thereof will receive a 100-point composite score comprised on their performance in these four categories. Scores that are, and at the beginning of each period, CMS will set a performance threshold. And so CMS will, in other words, set a performance threshold that will be between 0 and 100 points. And physicians who score at the threshold will not receive any payment adjustment. Physicians with scores below the threshold will receive a progressively large negative adjustment up to the maximum. And scores that are above the threshold will be eligible for bonuses up to a maximum. So in the first year of MIPS, the four performance categories are weighted as follows. Quality will comprise 60% of the composite score. Clinical practice improvement activities will comprise 15% of the composite score. And advancing care information will comprise 25% of the composite score. The cost/resource use category will be weighted at 0% for the first year. So again, here's kind of another explanation. Again, under MIPS, each eligible clinician or group thereof will receive a score that's between 0 and 100 points. That score will be comprised of these four different components: quality, resource use or cost, clinical practice improvement activities, and advancing care information. And clinicians who receive a score that is above a performance threshold that CMS will set at the beginning of each period will be eligible for bonuses. Clinicians and groups thereof that receive scores that are below the performance threshold will be penalized on a progressive scale. And to help make sense of that, here's a graph that sort of illustrates how that works. So you have this blue line here that runs vertical across the chart, and you can see that this represents a hypothetical performance threshold. And to the left of that, you can see how scores below the threshold result in progressively large penalties, and how scores above the threshold result in increasingly large bonuses. And in addition to that, you see this green line here. This green line represents an opportunity for additional bonuses. And essentially what will happen is that physicians who have a score that's higher than a certain second threshold that CMS will set each year will receive additional bonuses that are funded by a $500 million appropriation that has been made by Congress that's in place from 2019 through 2024. So physicians can receive bonuses for having a score that's above the threshold, and then additional bonuses if they surpass an additional threshold as made available through this $500 million per year appropriation. Some people ask, is MIPS a zero-sum game? In other words, what happens in the event that nobody's penalized and there's not an opportunity to assess penalties on anyone, and therefore, there's no money to fund bonuses? What happens then? If everybody exceeds the performance threshold, does anybody get any money? And the answer to that question is that in order to maintain budget neutrality, CMS can apply a scaling factor to the bonuses, and that scaling factor is up to 3, a scaling factor of 3.0 or less. And to explain how that would work, hypothetically, let's just say that at the start of a year, CMS anticipates that it's going to assess $200 million in penalties and award $100 million in bonuses. In that instance, CMS would double the size of the bonuses such that the total value of bonuses paid out would equal the total value of penalties assessed, or vice versa, which is to say that bonuses may be larger or smaller depending upon how many physicians are penalized, because the penalties will ultimately be used to help fund bonuses. The one exception to that, when I mentioned that additional performance threshold, the bonuses under that additional performance threshold are funded through a dedicated $500 million per year allocation from 2019 through 2024 and are not subject to budget neutrality requirements. So as I mentioned previously, CMS has established a transition period for the first year of the Quality Payment Program and MIPS. And in the first year of the program, they have set the performance threshold that I just mentioned to 3 out of 100. In other words, they have set the performance threshold at a very low level, as you can see from this illustration here. Now, physicians that don't report any data to CMS in the first year of the program can still be penalized, as you can see. But as long as a physician or applicable group receives a performance score of at least 3 out of 100 in the first year of the program, they can avoid a penalty. And as you can see here, opportunities for bonuses pending availability of funding from the assessment of penalties will still be available. In addition to that, those additional bonuses that I mentioned are also that are going to be funded through a $500 million allocation are also still available for physicians who meet the additional performance threshold, which will be set at 70 out of 100. I know that was a lot of information, so let me go back over it again. The performance threshold in the first year of MIPS is going to be set at 3 out of 100, which means that if you perform even a minimal amount of quality reporting, your practice will be able to attain a score of 3 and therefore avoid a penalty in the first year of MIPS. If you manage to attain a performance score that is higher than that, you may be eligible for some small bonuses. And in addition to that, if you manage to surpass a performance threshold, or attain a performance threshold of 70 or higher, you will also be eligible for additional bonuses out of that $500 million per year allocation that I mentioned. And those additional bonuses theoretically could be as high as an additional 10%. However, do keep in mind that aside from the bonuses that will be available for attaining a score of 70 or higher, other bonuses under the program will only be available to the extent that funding is available from the assessment of penalties. So I mentioned earlier that this is going to be a transition year for the merit-based incentive payment system. I know I've said that a few times now, but I think it's one of the few things that you really need to grasp is that for this first year of the program, the requirements, again, have been set at a minimal level. And for all intents and purposes, you have 4 options this first year when it comes to participating in the merit-based incentive payment system. One is simply don't participate. If you don't submit any quality data whatsoever, don't perform any improvement activities, and don't participate in all in advancing care information, you can receive the maximum penalty of 4% to your Medicare Part B payments in 2019. Option 2 is submit something. Again, you only have to attain a score of 3 out of 100 in order to avoid a penalty, and that means reporting on a single quality measure, similar to what you've done in the past on PQRS, or performing one of the new improvement activities will be sufficient to get you a score of at least 3 and thereby allow you to avoid penalties. And the second 2 options are similar. Essentially submit more than the minimum, and more is better. If you fully participate in the program, and we'll go over the requirements to do that, then you could potentially receive the highest possible score and therefore the greatest possible bonuses. So this is just a real high-level overview of the reporting requirements for full participation if you decide to fully participate in MIPS. And this isn't intended to be a comprehensive summary. It's still important that you go back and you do your research with respect to the reporting requirements, and I'll be happy to point you to some resources where you can get additional information as we move along here. But most participants, in order to acquire a maximum possible score under the quality segment of the merit-based incentive payment system, and remember, quality is weighted at 60% of the composite score, you would need to report on SITS measures for a minimum of 90 days. Again, report on SITS measures for a minimum of 90 days. And there are some special scoring criteria for certain alternative payment model participants. In the advancing care information category, you would need to report on the required reporting measures for a minimum of 90 days and select up to 9 performance measures Under the new clinical practice improvement activity category, depending upon your practice size, you would need to perform up to 4 clinical practice improvement activities, or CPIAs, for full credit. Examples of clinical practice improvement activities are extended office hours and timely communication of test results for patients. And again, special scoring criteria is available for certified medical homes and advanced alternative payment models. And so there is also a little bit of added flexibility for small practices and rural practices. On these next few slides here, we have a little bit more information about the specific criteria that you would need to meet under each of the categories. This information is included in the PowerPoint presentation that is available to all participants of our webinar, and you can look it over at your leisure. And in addition to that, again, we're going to be supplying you with some links that provide you with that information in more detail. One thing I do want to point out, again, as I mentioned early on, the CMS in its final rule substantially reduced the requirements that practices will need to meet in order to participate in the merit-based incentive payment system. There was no transition period with minimal reporting requirements under the proposed rule. Consequently, when CMS estimated the impact of MIPS on practices under its proposed rule, it estimated that nearly 80% of practices with fewer than 10 eligible clinicians would be penalized. Around 60% of practices with between 10 and 24 eligible clinicians would be penalized. More than 40% of practices with between 25 and 99 eligible clinicians would be penalized, and around 20% of practices with 100 or more eligible clinicians would be penalized under the proposed rule. Under the final rule, as you can see here in this comparison, very few practices are expected to be penalized due to the opportunity to report a minimal amount of data and thereby avoid a penalty. So how do you prepare for the merit-based incentive payment system? Again, review the exemption criteria that we discussed here in this presentation. Evaluate your performance under the existing programs that you're currently being subjected to. How are you performing in PQRS? Are you submitting data under PQRS? If so, reporting data under the quality component of the merit-based incentive payment system is very similar. Meaningful use. Have you been meeting meaningful use? If so, that's definitely something that gives you insight into whether you'll be prepared for advancing care information, which in some ways is sort of a scaled back version of meaningful use. And how are you doing in terms of your value-based payment modifier adjustments? Have you reviewed your quality resource and utilization reports, or QRURs, which are available for free from CMS, and which will illustrate how your practice is currently scoring in terms of quality and cost as determined by CMS. Review and select appropriate clinical practice improvement activities and quality measures, and study the specific details, the specific criteria that you will need to meet in order to successfully report on these measures. You can do this at the website that I've listed here, https qpp.cms.gov/education. This is a surprisingly well-built government website that provides a full explanation of the reporting requirements under the merit-based incentive payment system and a list of quality measures and clinical practice improvement activities that physicians can select from, including specialty measure sets. Consider your reporting options, whether you're going to report through a registry or EHR. And also, if you haven't done so already, it might not be a bad idea to contact your EHR vendor and ask them whether they're prepared to assist practices with reporting data under MACRA. So I mentioned earlier that, in the very first year of the program, not very many physicians are going to be eligible for the advanced alternative payment model track of the quality payment program and the corresponding bonuses. And a big reason for that is because Track 1 MSSP ACOs and bundled payments for care improvement are currently excluded from the definition of advanced alternative payment models. Part of the challenge here is that MACRA defines what an advanced alternative payment model is in kind of a specific way. It says that advanced alternative payment models have to do at least 3 things. They have to use certified EHR technology. They have to base payment on quality measures that are comparable to those under the merit-based incentive payment system's quality component. And they either have to require APMs to bear more than nominal financial risk or be a medical home expanded under CMMI authority. And that more than nominal financial risk part has been sort of the kicker for a lot of the existing payment models that are already out there, meeting that standard that CMS has set forth. Is a consequence of that standard. Track 1 MSSP ACOs and certain other types of payment models have unfortunately been excluded. Another thing to keep in mind is that you can't simply participate in an advanced alternative payment model. You have to significantly participate in an advanced alternative payment model, which means that a certain proportion of your Medicare patients or payments have to be linked to that advanced alternative payment model. And I don't think it would be too helpful to get into the details of this right now, except that I want to leave this slide here and make you aware that it's in the presentation so that you can see what those thresholds are and reach out to us if you have questions. Another thing that's kind of interesting is that, along with those thresholds I just mentioned, starting in 2021, in addition to your Medicare patient and payment volumes, you'll also be able to count participation in advanced alternative payment models that meet the criteria set forth by CMS with respect to other payers, such as private commercial insurance companies or Medicare Advantage plans or Medicaid HMOs. So in other words, beginning in 2021, your participation in an advanced alternative payment model with a private payer might help you earn bonuses under Medicare by meeting the specific volume thresholds that have been set forth under statute. So one of the reasons, though, that it is important at least to be aware of the advanced alternative payment model track of the QPP is that more advanced alternative payment models are coming down the pike. There's a two-sided oncology model that's going to be released in 2018. CMS is creating a new Track 1 Plus Medicare Shared Savings Program accountable care organization, which will require a relatively minimal level of risk that will satisfy the criteria under MACRA, but still enable physicians to ease their way into risk in a way that current two-sided MSSP ACOs do not. Possible expansion of the Comprehensive Primary Care Plus program, which may include Florida. In addition to that, some of you are probably aware that CMS has created a series of mandatory joint and cardiac bundled payment programs that apply to hospitals and that are being piloted across the U.S. And starting in 2018, physicians will be able to enter into arrangements with hospitals that are involved in these models that can also qualify as advanced alternative payment models under certain circumstances. And consequently, in other words, the range of available alternative payment models for physicians to participate in is going to be expanding quite rapidly in future years if things keep moving forward at their current pace. MACRA also creates a physician-focused payment model technical advisory committee, or PTAC, which will be working to assist CMS with creating new alternative payment models that physicians of various specialties can participate in. Remember, qualifying AAPM participants are exempt from MIPS, and they're eligible for considerable financial bonuses. And MACRA, because of the considerable incentives that it creates, could make advanced alternative payment models a widespread phenomenon. So looking forward, it's important to keep that into consideration. So key issues with MACRA, there are a few things that are particularly problematic about the law. One is that the payment updates that are scheduled to take effect under the law, while preferable to the SGR, do not keep pace with inflation. And you probably noticed that early on in the presentation when I mentioned that payment updates are going to be 0.5% through 2019 and then frozen for 5 years at 0%. Freezing the Medicare conversion factor or updating at a very slow pace that doesn't keep pace with inflation is obviously problematic for physician practices. And in addition to that, even with the considerable flexibility that CMS has provided under the transition period for MACRA, the program requirements are still burdensome, especially for small practices that have limited resources. An unfortunate reality is that small practices tend to shoulder a disproportionate share of the burden when it comes to the penalties that are assessed under these types of pay-for-performance programs because they, simply, lack the same resources as larger facilities, and unfortunately that can harm access to care and harm the patients that the physicians in those practices serve. We also need to be very careful about how we implement MACRA. CMS again has taken this cautious approach for the first year of the program, but ultimately there still needs to be more flexibility. We need to expand the availability of advanced alternative payment models so that physicians have more choice in terms of how they're paid. And CMS needs to listen to feedback from physicians, make sure that they're listening to caregivers as they promulgate rules in the future. Some additional facts about MACRA. MIPS payment adjustments don't apply to your in-network Medicare Advantage claims. Medicare Advantage contracts are still going to be negotiated with carriers, and may or may not include any sort of pay-for-performance component to them. The merit-based incentive payment system scores are going to be published on the Physician Compare website, so keep that in mind too. Whatever your scores are and the various components of the MIPS program and your overall MIPS composite score will be published, which builds upon existing transparency efforts that CMS has been supporting. So do keep that in mind, that your score under MIPS will ultimately be public. So I mentioned that the payment updates that are scheduled to take place under MACRA don't keep pace with inflation. And this graph here it sort of illustrates that. You see here there's a green line that represents the Medicare Economic Index, which is a measure of inflation for physician practices. It's a measurement of physician practice cost. And you can see that relative to the MEI, real payment update, the real value of payments made under the Medicare physician fee schedule are going to decline. In other words, payments under Medicare Part B are going to decline relative to inflation. And you can see here over the next 10 years, they're going to lose about 20% of their current value. And because the payment updates that are scheduled to take place under MACRA, again, don't keep pace with inflation and likely never will, you can see that the real value of Medicare payments over time will continue to decline if the law is implemented as currently written and Congress doesn't eventually make changes. And it's a serious issue. It's something obviously that the effects of this will become more apparent over the long term, but it's something that physicians should at least be aware of. Keep in mind that the payment updates you're going to receive in any given year aren't going to keep pace with inflation, and therefore, as you talk about the potential financial impact of MACRA on your practice, just keep in mind the effects of inflation and the potential effects of inflation in terms of eating away at the real value of your Medicare payments. And also, obviously, as you're budgeting for practice costs, keep in mind that the rate at which the Medicare physician fee schedule changes may not keep pace with certain rising costs. That's an unfortunate reality. That is something that hopefully Congress will eventually address. But as it is, the updates to the Medicare physician fee schedule conversion factor are not scheduled to keep pace with inflation. And you can see here that over time that will lead to substantial reductions in the real value of Medicare Part B payments. So one of the questions that I sometimes get is, is there anything good about MACRA? Well, there are a few things to keep in mind that I think are worth noting. One, obviously, is that MACRA got rid of the SGR, and the SGR had the potential to result in substantial payment cuts to physicians. But moreover, MACRA also increases the possibility of earning bonuses under the Medicare physician fee schedule, and it actually decreases the range of penalties that can be assessed on practices relative to prior law. So if we look here on this chart that the American Medical Association put together, you can see in 2019, in payment year 2019, physicians that had failed to perform under meaningful use could be assessed a penalty of 5%. And an additional penalty of 2% could be assessed on physicians and physician groups that did not participate in PQRS. And payment updates, negative payment adjustments under the value-based payment modifier could have been 4% or more for combined penalties of 11% or more. Under MIPS, the maximum penalty is only 4% in 2019. So and in addition, as I mentioned, physicians will have an opportunity to earn bonuses under MIPS in 2019 if they score beyond the performance threshold. And as you can see, even the maximum penalties under MIPS in 2022 and beyond are still less than the maximum penalties under the 3 programs that preceded it. So in other words, one way of putting it might be that MIPS and MACRA generally are problematic, but it could be worse. Prior law was actually worse. And so while MACRA certainly doesn't solve all of the many problems that exist under the Medicare physician payment system, it does slightly alleviate some issues. And it's overall, in some ways, a step in the right direction. So I mentioned again that Medicare Advantage plans and contracted Medicare Advantage payments are not subject to MIPS. Medicare Advantage participation levels in Florida, as you can see from this map from the Kaiser Family Foundation, are fairly high. Nationally, around 31% of Medicare patients are in a Medicare Advantage or Medicare Part C plan. In Florida, that number is around 40%. So a brief summary of MACRA. Again, remember, if you learn nothing else, most positions and groups thereof are going to be subject to the merit-based incentive payment system in 2017. The start date for reporting, if you intend to submit 90 days of data under the program so that you can try to attain a higher performance score, will be obviously anywhere between January and October. Flexibility under the program and the first year of the program, again, has been announced. The performance threshold that physicians will need to meet under MIPS to avoid a penalty is 3 out of 100, which is, in future years, this sort of transition policy and this reduced performance threshold is unlikely to continue. It's possible that CMS may expand this flexibility for another year, but one should assume, cautiously assume, that CMS is ultimately going to phase in more requirements under the merit-based incentive payment system, and that avoiding penalties and earning bonuses will become more challenging in future years for a variety of reasons. Now, whether the incoming administration will make any sort of additional changes through the regulatory process that might be beneficial to physicians is something at this point in time we can do nothing more than speculate on. So again, just remember, this is just the first year of the program. Implementation is going to continue. So one thing I want to mention is, when we talk about MACRA, it's important to remember that the changes that are taking place to the Medicare physician fee schedule are also occurring in the context of a broader payment reform movement. CMS is aggressively, at least under the Obama administration, seeking to rapidly implement alternative payment models and pay-per-performance programs. And it was CMS's goal under Secretary Burwell to have 50% of traditional Medicare payments tied to alternative payment models by the end of 2018. Again, what the new administration will do is up in the air. But keep in mind that so far, that has been the direction that CMS has been moving in. Again, CMS has been very aggressive at looking for ways to create alternative payment models. They have, for example, created the mandatory CJR, joint replacement program for hospitals, and they are looking to expand CJR to include surgical hip and femur fracture treatments in the middle of this year. They're also implementing new cardiac mandatory bundles for hospitals that will include AMI and CABG beginning in the middle of this year. Not all hospitals in all regions will be affected by these new mandatory bundles, but these changes, these pilot programs, are being rolled out in various localities nationwide. For example, the current CJR program that's been in effect since April 2016 includes over 800 hospitals, including several hospitals in Florida. And that pilot program is scheduled to continue for 5 years. One of the good things, potentially good things, I'll say, about some of these mandatory bundles that are affecting hospitals is that starting in 2018, they will qualify under certain circumstances as advanced alternative payment models. So in other words, and maybe in future years, a pathway for physicians to exempt themselves from the requirements of MIPS and to earn substantial monetary incentives that are provided for under MACRA. This slide illustrates the growth and participation rates amongst physicians and accountable care organizations. This is self-reported data from the most recent Medscape survey. ACO participation levels, as self-reported by physicians, is now over 30%, and this is consistent with surveys from other sources as well. And there are also additional physicians that are looking to participate in an accountable care organization. The point being, again, that the payment reform movement has been moving very, very rapidly. It's something that's really has been sweeping the nation, and now that more than 30% of physicians report participating in an ACO. You can see here again that this is something that if the payment reform movement hasn't affected you yet, if the current trend continues, it likely will in the not too distant future. Here's just a map of accountable care organizations, specifically Medicare Shared Savings Program accountable care organizations in Florida. You can see that they're spread over the state, but concentrated especially in the central part of Florida and the southern part of Florida in the Palm Beach / Miami area. And this is a map of Medicare Shared Savings Program assigned beneficiary populations nationwide at the county level. And you can again see that there's a heavy concentration of Medicare Shared Savings Program ACO participants in Central and South Florida. So again, you can really see how these reforms are sweeping the nation. I realize that when we're talking about MACRA and the changes that are occurring to Medicare Part B, obviously Medicare Part B is a different proportion of everyone's paramedics, but it's important to remember that enrollment in Medicare Part B is growing. The proportion of the population that is enrolled in Medicare is growing. For example, in 2016, it's estimated by CMS that there are around 56 million Medicare beneficiaries. By 2021, it's expected that there will be around 64 million Medicare beneficiaries. In other words, a 14% growth in enrollment over just a 5-year span. And you can see here that CMS and MedPAC anticipate that enrollment in the Medicare program is going to rapidly climb in the coming years. In other words, reforms that occur in the context of traditional Medicare are going to have an increasingly large impact on physicians across the nation, and especially here in Florida, where a substantial portion of our population growth has been driven by an influx in seniors. Furthermore, projected net Medicare spending is anticipated to double between 2016 and 2026. So you can see here an illustration of actual and projected net Medicare spending from 2010 through 2026. And what you'll see here is that from 2015 to 2026, it's expected that net Medicare spending is roughly going to double in that short 10-year time span. So again, when we talk about the amount of money that's at stake under MACRA and under Medicare Part B and under MIPS, just keep in mind again, enrollment in Medicare is growing and spending under the program is growing, and therefore we can anticipate that the impacts of reforms to the physician payment system under Medicare are going to continue to increase over time. And you can see here just on this slide that Medicare is by far the largest federal health care program in terms of the level of spending provided by Congress. You can see here that, for example, the Affordable Care Act subsidies and related spending in 2016 are expected to cost about $43 billion, whereas Medicare spending net of offsetting receipts is expected to cost closer to $600 billion, just to give you some idea about the size of the program. And so here are some references. Certainly, you can read these over at your leisure. Contact me if you have any questions. I want to say, thank you. So again, today we talked a little bit about the history of MACRA. We talked about its major provisions, and we talked about the merit-based incentive payment system and incentives for advanced alternative payment models and how they together form the quality payment program. And then we went into a little bit of detail about how the merit-based incentive payment system is going to work in practice. Talked about where you can find some additional information about how to implement MIPS in your practice, and talked a little bit about the future of the Medicare program. And so with that, I'm going to close, and thank you for your time. Please contact me if you have any questions.